Hello, my name is Christy Lee, and I am part of the Division of Respirology and the Interdepartmental Division of Critical Care Medicine. And I'm here today to talk to you or give you an introduction to respiratory failure and mechanical ventilation. I have no relevant disclosures. The lecture is designed to meet the following end-of-week learning objectives: to describe an approach to respiratory failure, specifically an approach to hypoxic and hypercapnic respiratory failure, and describe how mechanical ventilation may support respiratory failure. By the end of this module, you should be able to describe the common signs, symptoms, and investigations for respiratory failure, describe the two main types of respiratory failure, understand the physiological causes for respiratory failure, and describe a theory behind which mechanical ventilation is used. Respiratory failure. What exactly is that? Well, the reality is there are many different approaches that we can take to respiratory failure. Some people like to use an organ or system approach, meaning go by different organ systems within the body. Some people like to think of it in a physiological way, and then others might like to think about it more from a clinical perspective. The two main types of respiratory failure that we oftentimes think about are failure to oxygenate, so hypoxic respiratory failure, and failure to ventilate, or hypercapnic respiratory failure. Before we talk a little bit about what the types of respiratory failure are, I think it's actually more important to think about what some of the common symptoms are. When you see patients, really the most common symptom that you're going to complain or they're going to complain about is going to be shortness of breath. In addition, they might also complain a bit about feeling tired, having limitations in their activities, feeling anxious because they're always short of breath or tired. They might, over long periods of time, start to complain about lightheadedness, and sometimes in chronic periods, ankle swelling. When you see a patient that you think might have shortness of breath or respiratory failure, there are many important questions that you need to ask. First off, you need to ask about all the potential primary causes or aspects of the complaint. When did it happen? How long has it been going on? What makes it better? What makes it worse? You should always ask about smoking and infectious history or contact. Any potential relevant past medical history, in particular primary pulmonary conditions like asthma or COPD or cystic fibrosis. You always want to get a good occupational history because it helps to elicit any potential environmental exposures. You want to know about drug exposure, other environmental exposures such as where they live, whether they've done renovations, do they have any pets or exposures to certain animals, and finally, certain things that need to be ruled out. There are lots of things that might potentially mask as respiratory failure, and shortness of breath doesn't occur just in patients with primary pulmonary conditions. The main thing you have to think about are patients that might have cardiac congestive heart failure or pulmonary edema, which may also sometimes present as shortness of breath. Once you've done a good history, you're going to then look for specific signs on physical exam. The first and foremost, are they tachypnic? What is their oxygen saturation? Is it low? Do they have evidence of hypoxemia? This is basically a low partial pressure of oxygen within the arterial blood, and this is denoted as a PaO2 of less than 80 millimeters of mercury. Do they have evidence of cyanosis on physical exam? And are there any other abnormalities as part of the respiratory exam, such as pursed lip breathing, accessory muscle use, or adventitious sounds on auscultation of the chest? After you examine the patient, you always have to do some investigations. Some of the specific investigations that you would do for respiratory patients include an arterial blood gas. A blood gas is a sample that you take from the radial artery to actually document hypoxemia within the blood. You need to get a chest x-ray to make sure that the lungs themselves look normal and that there are no other abnormalities such as pleural effusions, pneumonia, or consolidation. You need to get a CBC because sometimes in patients that are chronically hypoxic, their hemoglobin becomes very high to try and improve gas exchange and oxygen carrying capacity. You'll need to get electrolytes, including a bicarbonate, because sometimes the bicarbonate will be abnormal depending on whether they've been chronically hypercapnic. So now moving on, I'd like to talk a little bit about hypoxic or hypoxemic respiratory failure. From my perspective, the easiest way to approach hypoxemic respiratory failure is to look at the physiological causes. I will be providing a list of 5 main things that we will elaborate much more on Monday's lecture. This is really just to give you a sense of what these things are. The most common situation or scenario that you're going to see is going to be VQ mismatch. It is by far the most common physiological cause for hypoxemia. Other causes might potentially be things like shunt, hypoventilation. This is the situation in which you have increased CO2 within the blood and difficulty clearing the CO2. Patients might have diffusion abnormalities, so if something is actually wrong with the actual barrier between the alveolar membrane and the interstitium or capillary membrane to prevent diffusion of gas across the barrier. Things like interstitial lung disease or pulmonary vascular disease might do this. And finally, low inspired FiO2. This is really not an issue for normal people at sea level, but if you decide to take a vacation and go to Mount Everest, this might be a major problem. The barometric pressure is much lower at altitude, at high altitude, and therefore the actual amount of oxygen available and the amount of oxygen within the alveoli is much less. I only also bring this up because in our patients within the hospital, oftentimes you'll see them connected to supplemental oxygen, things like nasal prongs or potential a face mask. In these situations, if their saturation is still low, I always follow the tubing and make sure that the tubes are actually connected to the wall and to the source of oxygen, because oftentimes you'll find that sometimes they're just disconnected. Sometimes people like to look at some clinical causes of hypoxic respiratory failure or hypoxemic respiratory failure. The most common things that you're going to see are going to be things like pneumonia, heart failure or pulmonary edema, ARDS, aspiration pneumonia, multi-trauma and direct injury to the lung, like contusions, pulmonary emboli, and finally drug or toxic metabolites and exposures. These are usually the most common things that will cause hypoxemia within our patients. The second type of respiratory failure is caused by hypercapnia. As you remember, CO2 is the most common form of respiratory waste by your tissue. Normally, when we measure a PaCO2, so the CO2 within the arterial blood, it's measured at around 40 millimeters of mercury. When the CO2 rises, patients become more acidotic, resulting in respiratory acidosis. This process can be potentially acute or chronic in nature. Don't forget that CO2 diffuses 20 times faster across the alveolar blood gas barrier than oxygen. When we think about hypercapnia, you have to remember that CO2 is actually very tightly controlled within the body. Any rise in CO2 will actually send a very strong signal and stimulate an increase in your respiratory drive within the brain. Whenever I think about arterial CO2 content, I really break it down into two parts. You have to remember that it is always balanced by what is going in and what is coming out. So what's going into the blood, which basically is denoted by the CO2 production, is oftentimes denoted as VCO2. CO2 removal, or getting rid of carbon dioxide, really depends a lot on alveolar ventilation. When you remember your talks on respiratory physiology, you'll remember that with every breath that you take, you are creating what's called a tidal breath, or tidal volume. That's the volume of gas that is being exchanged with each and every breath. Over the course of a minute, when you multiply your tidal volume by your respiratory rate, you will get what's called a minute ventilation, which is denoted by V subscript E. Don't forget that not all of the volume in your tidal breaths are actually contributing to gas exchange. Your tidal volume is made up of dead space, areas of lung that are being ventilated but not perfused. For example, your trachea, your mainstem bronchi on the right and the left, all the way down to just before your respiratory bronchioles. Alveolar ventilation, which is the other component of tidal volume, is actually the part of your lung that contributes to gas exchange, and that's denoted by a V subscript A. And so whenever you look at somebody's arterial CO2, you always have to remember whether or not the abnormality is in terms of too much is being made or not enough is being removed. When we think about physiological causes of hypercapnia, there are really three main things that we think about. The first two are related to CO2 removal. VQ mismatch and hypoventilation are probably going to be the two most common causes of hypercapnia. And we'll get a little bit more into details about this within the lecture on Monday. Increased CO2 production is a very uncommon cause for increased CO2 or hypercapnia. Oftentimes this will happen in hospital in either a hypermetabolic state where patients' basal metabolic rates are up, as seen in some endocrine conditions, or in patients that have been chronically malnourished and suddenly get overfed. Some drug overdoses may also potentially increase your CO2 production, but the two most common are really VQ mismatch and hypoventilation. When we think about hypoventilation, there are really two types. Either the patient can't breathe, meaning that there's actually a deficiency in the ability to ventilate, so sometimes that's a respiratory muscle problem, or they won't breathe. There's something wrong within their central respiratory center that won't allow the patient to trigger a breath. I like to use this slide because personally, from my perspective, I like to think about the potential pathway from how we end up breathing. The signal for breathing really starts from the brain in the respiratory center that then gets sent down your spinal cord and then down your neuromuscular junctions, then innervating the diaphragm. You also have intercostal muscles that are also involved. Within the lung, you have to think about potential airway and lung parenchyma. If there are ever any abnormalities in any of this part of the pathway, you might potentially lead to hypercapnia. So when we look at the bottom of the slide, where we're looking at conditions that can cause respiratory failure, I like to think about these kinds of things. In the brain, anything that affects the respiratory drive, such as a stroke, drugs, or alcohol overdose, might potentially decrease the respiratory drive, thereby reducing your ability to want to breathe. Other things from a neuromuscular perspective, which is on the bottom left of the screen, would be things like diaphragmatic weakness, spinal cord injuries preventing innervation, muscular dystrophy, and ALS. These things are primarily problems with relation to the respiratory muscle function. When you start to move into the airways, you can think about things that might prevent the flow of air, such as COPD, cystic fibrosis, which are very common conditions. Or you can think about parenchymal problems, things like ARDS or pneumonia, where the actual alveoli themselves are being plugged by pus or fluid, preventing gas exchange. Anything that prevents gas exchange might also limit your ability to clear CO2. Finally, within the blood vasculature in the pulmonary circulation, you can develop clots like pulmonary emboli, which will also cause lung damage and prevent CO2 clearance. So there are many strategies and approaches to the way that we can try and solve hypercapnic respiratory failure. What I'd like to do now is switch gears and talk a little bit about mechanical ventilation. As I mentioned in the beginning, we will be going much more detail about all of these topics on Monday during the actual lecture. Suffice to say, for this part of the talk, what I'd like to do is just talk a little bit about the history of ventilation, because ventilation is really not that new of a thing. The first documented case of mouth-to-mouth resuscitation probably was actually denoted within the Old Testament. But the first attempt at trying to actually ventilate someone with a tool or a mechanical device would have been back in 1543, when Andreas Vesalius took a fire bellow and basically inserted it into a pig's mouth and pushed on the bellows and watched the chest rise within the pig. In essence, what he did was he had put the pig to sleep, and then, by using the fire bellows, able to move the chest up and down, creating respiration. Paracelsus did the same kind of thing with fire bellows in patients in 1550, and further research was done by Hooke, doing same kind of bellow ventilation in dogs in the 1600s. But nothing significant really happened until probably 1744, when there was a first published case of successful mouth-to-mouth resuscitation by J. Fothergill. In this situation, there was a patient that actually had a cardiac arrest, and someone then did mouth-to-mouth resuscitation, facilitating ventilation, allowing the patient to recover. In 1775, J. Hunter then used this concept of double bellows, where he used one set of bellows to push good air in, and then another set of bellows to try and pull bad air out, to try and mimic respiration in people that had respiratory failure. These were all pretty archaic, and I would say probably the first thing that was the closest to what I would call a mechanical ventilator was in 1911. Heinrich Draeger, who was actually a watchmaker, was very interested in helping to assist patients that had suffered from either drowning or potential fire victims. And what he did was he created a machine with a mask and some tubing and attached it to pressurized air air canister. On the outside of the box, you can see there was a rotor that he can turn either clockwise or counterclockwise. When he put the mask on the patient and then turned it clockwise, the air would then come out of the tank and provide positive pressure ventilation to the patient, causing a chest rise. In order to mimic expiration, what he would then do is turn it counterclockwise and essentially suck air out of the lung, creating a negative pressure force, mimicking a proper respiratory cycle. Since then, we've made sort of lots of progresses in terms of mechanical ventilation. What we wanted to just touch on very briefly here was that the indication for mechanical ventilation is really much more sophisticated now than back in 1911. We really have three main reasons why we would want to initiate mechanical ventilation in our patients. First and foremost, the most common will be respiratory failure, either oxygenation or ventilation failure. The second most common reason is usually because of airway protection, either because of altered level of consciousness, traumatic brain injury, absence of reflexes, or too many secretions that the patients can't manage. Patients might need mechanical ventilation to help assist in breathing. Finally, patients that are sick or have an increased work of breathing, high drive, or increased oxygen requirement by respiratory muscles might benefit from some support on a mechanical ventilator. Nowadays, mechanical ventilation is much more different than what we used to see with the Draeger pulmotor. We have many different mechanical ventilation devices and many different ways that we can develop mechanical ventilation or deliver mechanical ventilation. The two main types really are non-invasive and invasive. Non-invasive ventilation essentially means that you're delivering positive pressure from a machine through a mask or through a helmet. In these situations, patients are expected to be breathing spontaneously and can trigger the ventilator to help them with every breath that they take. We generally don't recommend this type of mechanical ventilation if patients are very sick, meaning they are very hypotensive, acidotic, or have an increased risk of aspiration. So for instance, patients that might be at risk of vomiting should really not be considered for a non-invasive mask, because in case they vomit and they aren't able to actually get rid of the vomit, they might potentially aspirate that into their lungs. Invasive ventilation is when we deliver positive pressure air through either an endotracheal tube, so a tube that goes through the mouth into the trachea, or through what's called a surgical airway. A surgical airway means that the tube is going directly into the trachea from within the neck. In these situations, patients can potentially be spontaneously breathing, so breathing on their own with assistance, or if they're very, very sick and aren't able to breathe on their own, then the machine will breathe for them, which is called a controlled mechanical ventilation. There really aren't any major contraindications to invasive ventilation. What I'd like to do now is sum up some of the key messages from this module. There are many different approaches to respiratory failure, but there are really two main types of respiratory failure that we recognize. They are hypoxemic and hypercapnic respiratory failure. In both cases, VQ mismatch is really the most common reason for respiratory failure, and mechanical ventilation is a form of assisted ventilation that we can use and can either be invasive or non-invasive to help our patients. By now, you should be able to describe some of the common signs, symptoms, and investigations for respiratory failure. You should be able to describe the two main types of respiratory failure and have a general understanding of what the different physiological causes are for respiratory failure. Finally, you should be able to describe some of the theory behind how mechanical ventilation came to be. Thank you very much, and I hope you enjoyed this module.